I'm Dr. Ross, and again, welcome everybody to our updates in urologic oncology. It's a pleasure tonight to introduce Dr. Amarasekera. He's an assistant professor of urology at Northwestern, and he's a clinical focus on men's health, sexual medicine, and reconstructive surgery. He's a director of our gay and bisexual men's urology program, which is the nation's first urology clinic targeting the needs of gay and bisexual men. Our aspiration with his leadership is to improve the urologic care experience, outcomes, and quality of life for people who are assigned male at birth but identify as gay or bisexual. Tonight, Dr. Amarasekera is going to talk to us about prostate cancer in gay and bisexual men. Channa, really a pleasure to have you. Thank you very much for being here, and please take it away.
Thanks, Dr. Ross, for that very kind introduction. It's an honor to be here. And I'm very happy to be talking about prostate cancer in gay and bisexual men. I had no disclosures, and the three main objectives here are to learn about the current clinical terminology used to identify sexual minority patients, the unique impacts of prostate cancer on gay and bisexual men, and then how HIV infection influences prostate cancer screening and treatment. So in terms of an outline, we'll go over some history, some definition, talk about healthcare disparities, and then dive into prostate cancer in gay and bisexual men, prostate cancer and HIV, and then transgender patients and prostate cancer. To understand prostate cancer or health disparities in LGBT patients, it's important to look at the history of LGBT people in America. And it wasn't too long ago that LGBT people weren't all that accepted in society. So in 1924, there was the first gay rights organization here in Chicago. It was the nation's first one. It was the Society for Human Rights. In 1948, Alfred Kinsey published The Sexual Behavior in the Human, and that gave a sort of a spectrum of human sexuality going from 1 to 6 in terms of where people are. In 1952, the American Psychiatric Association Diagnostic Manual it listed homosexuality as a sociopathic personality disturbance. In 1953, gays weren't able to serve in the federal government because they thought they were a security risk as they could be blackmailed. In 1962, Illinois was the first state in the U.S. to decriminalize homosexual acts between consenting adults in private. And in 1969, there was a riot at Stonewall Inn in Greenwich Village in New York City to fight back during a police raid. And here's a newspaper clipping from that time, which is a real headline, which is quite sensational. In 1973, the APA removed homosexuality from the DSM. In 1981, unfortunately, there was an unusual cluster of PCP in 5 gay men, and this was the start of recognizing the AIDS epidemic. It took 4 years and hundreds of thousands of lives for the President of the United States to publicly acknowledge AIDS, and that was in 1985. In 1993, there was the Don't Ask, Don't Tell policy, which permitted gays to serve in the military, but it banned homosexual activity. In 1996, DOMA was enacted, and that banned federal recognition of same-sex marriage. But then things started to change pretty quickly after that point. In 2003, the U.S. Supreme Court ruled in Lawrence versus Texas that sodomy laws in the U.S. are unconstitutional. In 2004, Massachusetts became the first state to legalize same-sex unions. But it wasn't until 2015 that the Supreme Court ruled that same-sex couples could marry. And then in 2018, you have the first openly gay governor who was elected in Colorado. In 2020, you have equal protections under federal law in terms of protections against workplace discrimination. In 2021, we have Pete Buttigieg, who's the Secretary of Transportation, and he's the first openly gay member of the cabinet. And in 2021, you also have the first openly gay active NFL player. But it hasn't always been progress forward, particularly in the last 5 years. There was initially a transgender military ban, which has since been overturned, thankfully. And then during the time of Trump's election, there was an increase in crisis support line calls by LGBT people. And in this particular law, giving healthcare workers new religious liberty protections was enacted. And there is some concern that this may give people cover for discrimination in terms of healthcare providers. When you're talking about the gay community, there's a lot of diversity among gay and bisexual men by age, race, education, income, family structure, lifestyle choices, self-expression, and their degree of outness. So they're not, one uniform group. And it's important to note that sexual orientation and gender identity are not the same. All people have a sexual orientation and a gender identity. And how people identify can change over time, and the terminology varies. So when you think about sexual orientation, it's how a person identifies their physical and emotional attraction to others, and it consists of desire, behavior. There are men who have sex with men and women who have sex with women, and identity. So do they identify as straight, gay, bisexual, lesbian, queer, or something else completely? In terms of gender identity, it's a person's internal sense of their gender. So do I consider myself male, female, both, neither? And all people have a gender identity. Gender expression, on the other hand, is how one presents oneself via behavior, mannerism, speech patterns, dress, hairstyle, and it may be on a spectrum. Transgender, it is when gender identity or expression is not congruent with sex assigned at birth. And in terms of terminology, there's a transgender woman, trans woman, male to female, transgender man, trans man, female to male, and non-binary or genderqueer. So there's many reasons why there's poor health outcomes in LGBT patients, and there's this model that explains why they might have poor outcomes, and that relates to different types of stigma. So interpersonal stigma like societal homophobia, family rejection, peer harassment, intrapersonal or structural stigma, which is where we fit in, where there's homophobia within healthcare, educational setting, employment discrimination, housing discrimination, religious exclusion, and this can lead to intrapersonal stigma, where there's internalized homophobia, low self-esteem, depression, self-harm, self-validation through sex, all of which can lead to stress, anxiety, depression, and healthcare disparities. There's some degree of literature documenting negative interactions in healthcare settings for LGBT patients. So they cite prejudice, assumptions, a lack of sensitive or knowledgeable providers, and few support groups and inclusive information. Because of the disparities in healthcare, the Institute of Medicine in 2011 started to address this. So there's building a better foundation for better understanding, where they wanted to collect data on sexual orientation in the health record. And that was also, again, in 2013, they reiterated this. The Office of Disease Prevention and Health Promotion in 2020, they had the Healthy People 2020 initiative. And the reason they did this was because they found that LGBT youth were 2 or 3 times more likely to attempt suicide. They're more likely to be homeless. They found that MSM, or men who have sex with men, are at higher risk for HIV, STDs, especially among communities of color. And LGBT populations have the highest rates of tobacco, alcohol, and other drug use. And they also found that lesbians are less likely to access screening services. As a result, there's a variety of health outcomes that are poor for LGBT patients, and they have to do with regular chronic conditions like hypertension and heart disease, but also things that have to do with health risk behaviors like drinking, smoking, and mental health issues. So one of the other reasons LGBT patients have poor health outcomes is because physicians may not always be comfortable with LGBT patients. Fortunately, this has changed over time. So in 1982, there was a survey of San Diego County Medical Society's physicians, and this was repeated in 1999 and 2017. And what they found was in 1982, 30% of people who were polled said they would not admit a highly qualified gay applicant to medical school, whereas currently, or in 2017, that was 0.4%, so a huge change there. And in 1982, they wouldn't refer a child to a gay pediatrician, and 46% of people said that, or physicians said that, and that's now much lower at 3%. However, there's still a great deal of stigma around HIV infection, so about 27% of physicians would not refer to a HIV-positive general surgeon. What they found was more recent graduates were less likely to be homophobic and HIV-phobic, and homophobia was correlated with the fear of HIV-infected people. So we talked about 2020, Healthy People 2020. 2020 has now come and gone, and there's been some progress, but there's still a lot to be done. So there's Healthy People 2030, which is the Office of Disease Prevention and Health Promotion's goals for LGBT health, and these are a little more specific. So they'd like to reduce bullying of LGBT students, reduce drug and alcohol abuse, suicidal thoughts in LGBT high school students, increase national surveys that collect data on LGBT populations, increase the number of states and territories that include sexual orientation, gender identity data in the behavioral risk factor surveillance system, and reduce the rates of STIs and HIV in LGBT people. So one of the easiest ways to get information about your patient's sexual orientation is just to include it with the demographic form at the start of the clinic appointment. This way, patients are able to disclose who they are before they even talking to you, and it can make the conversation much easier when they see you. Because it can be, pretty difficult to discuss issues of intimacy during a clinical encounter. But taking a sexual history for urologists is very important. The core comprehensive history for LGBT patients is the same as for all other patients, just keeping in mind unique health risks and issues for LGBT populations. And you should get to know your patient as a person, use inclusive and neutral language, and for all patients, just make it routine, make no assumptions, and assure confidentiality. One of the pitfalls of talking to patients who are LGBT is they may prefer a different pronoun than the one you're used to using. So it's important to use the patient's preferred name and pronouns. For example, most transgender women want you to say she or her when talking about them. Trans men generally prefer he or his. Some people may use words or pronouns that are unfamiliar. Pronouns such as ze or they are sometimes used by people who don't identify with the gender binary of she and he. And then there's other terminology that is a little different from what it was traditionally. So queer was traditionally an insult, but some people, especially young people, use this term with pride to identify their sexual orientation as non-heterosexual. And then there's genderqueer or gender fluid, used by some people to describe their gender identity and expression as both male, female, or neither male nor female. And it's also described as rejecting the gender binary. And some people don't like labels at all. In terms of terms that are outdated, homosexual is currently outdated. People prefer gay, lesbian, bisexual, or LGBT. Transvestite or transgendered is outdated. It's transgender. Sexual preference or lifestyle choice is also out of date, and sexual orientation is what's preferred. So there are obvious don'ts, which include using disrespectful language, gossiping about a patient's appearance or behavior, saying things about someone that are not necessary for their care. And then just sticking to asking questions related to a patient's healthcare and not just to satisfy your own curiosity. So in terms of cancer in this population, the rates of cancer, gay men are about 2 times more likely to have a cancer diagnosis. And this was obtained through the California Health Interview Survey data, which had information about 50,000 respondents, 1,500 of whom were gay or bisexual males. There was more head and neck cancers in men who have sex with men who had oral sex. And there were higher rates of anal cancer in men who have sex with men who had anal sex. The higher rates of cancer, however, may be explained by more AIDS-defining cancers like sarcoma or non-Hodgkin's lymphoma in this group, and also more cancers associated with HIV, such as anal and lung cancer and Hodgkin's lymphoma. In terms of prostate cancer in gay and bisexual men, this is a new area of research, and you can start seeing the first papers kind of trickle in about the turn of the century, the year 2000 or so. The entire literature is about a little bit over 100 papers. They're mostly qualitative data or case reports. And that, a large part of that is because data on sexual orientation is not captured routinely in cancer registries. So there's not great, population level databases with sexual orientation as a field, or traditionally there has not been. In terms of PSA screening and prostate cancer, in a large study using NHIS data with 22,000 men, 574 of whom were MSM, there were no differences in PSA screening rates between gay, bisexual, and straight men in 2018. Prior to this, gay men actually screened at higher rates with an odds ratio of 1.5. However, it's a slightly different story for African American gay men. They're about 14% less likely to have a PSA compared to their African American heterosexual counterparts, and 28% less likely to test than gay white men. In terms of another data set, there's a seer cancer registry data from Washington State, and they found no change in prostate cancer risk by sexual orientation, history of male partners, or anal sex, or a history of anal sex. In terms of how gay men and bisexual men choose to be treated for prostate cancer, there are similar rates of treatment between heterosexual men and gay men. So in this particular study, looking at 460 heterosexual men and 92 gay men, they found that about 80 to 85% of people underwent surgery for treatment, and about 26 to 28% underwent radiation. Because the side effects from surgery and radiation can be different for gay men compared to straight men, there are some who advocate asking patients about their role in sex to assist with treatment choice. So if they are receptive partners, there's some thought that surgery might be better because radiation can cause some rectal fibrosis when it comes to being the receptive partner. And then if they're the inserted partner, radiation might be a better choice because erectile function is most important there, and there's not such a emphasis on rectal health. But discussing the risks and benefits of both are appropriate if they practice both types of intercourse. Despite these recommendations, there's really no long-term differences in erectile function and bowel urgency between men getting radiation or surgery. In terms of health-related quality of life, overall, gay prostate cancer patients experience lower health-related quality of life. There's a study in 2016 looking at 124 gay and bisexual men and 225 heterosexual men. And gay and bisexual men scored lower on the FACT-P and had greater degree of psychological distress, so greater degrees of anxiety, panic, depression. And this was thought to be due to a greater degree of bother from side effects, of fear of recurrence, and just generally lower satisfaction with care. But the extent to which the lower health-related quality of life is from prostate cancer is unclear, just because gay and bisexual men have greater levels of depression and psychological distress at baseline, even without a cancer diagnosis. In terms of erectile dysfunction, so in the same study, the erectile function score for gay men was actually better than for straight men. So they had an epic of, straight men had an epic of 21 versus, gay men had an epic of 21 versus 16. And then there was a different study that looked at 89 gay and bisexual men and compared to published population norms, and they found an epic score of 38 versus 29, which was statistically significant there. In terms of bother from erectile dysfunction, there were higher levels of bother seen in men who have sex with men, about 81% in a study by Usher. And this might be due to expectations of having an active sex life well into their later years. It could also be a loss of opportunity to explore recently accepted sexuality, particularly for men who came of age, men who are older, who came to terms with their sexuality much later in life. And there's some data that gay men are more sexually active, more likely to be non-monogamous. In a survey of 1,000 gay and 2,000 straight men in 2011, 56 to 61% of gay men were noted to have sex outside of their relationships versus 10 to 15 of straight men. And it could also be that firmer erections are needed for anal intercourse compared to vaginal sex. So having a certain degree of erectile dysfunction may make it impossible to have anal sex, where you could potentially have vaginal sex with the same degree of erectile dysfunction. In terms of ejaculatory function and bother, gay men consistently report poor ejaculatory function after prostate cancer. They also display more bother with loss of ejaculatory function. And ejaculatory bother may be greater due to HIV prevention campaigns. So these targeted at drawing attention to the management of ejaculation during the height of the HIV epidemic. And more gay men feel that ejaculate serves as visual evidence of satisfaction or a sign of good sex. When it comes to changes in role in sex, as we sort of alluded to before, treatment can lead to changes in sexual roles. So if they're the insertive partner or the receptive partner, things can change because of treatment. So there's a study, again, looking at roles pre-treatment, and in this particular study, 31% of partners were the inserted partners before treatment, 19 were receptive, and 20% were versatile. And then post-treatment, 12% were insertive or tops, and 24% were receptive or bottoms, and 8% were versatile. So there was a change with treatment. And changes can lead to changes in role in sex can lead to a loss of sexual identity. So what they found was inserted partners didn't want to switch because they perceived being the receptive partner as a submissive role, or they didn't want to switch because they didn't find the new position pleasurable, or they were in relationships with partners who were exclusively interested in one role, so it didn't make sense for them to switch. But switching roles is not universally viewed as negative. Repositioning does allow for sexual engagement after treatment, and some of the participants of this study noted this as well. When it comes to measuring sexual function in men who have sex with men, instruments measuring sexual function or erectile function were validated mostly in straight cohorts. So when it came to EPIC, all men were presumed to be straight, and when it came to the MSHQ, there was a small proportion of participants who were MSM. So this has led to the development of other measuring devices or measuring instruments. There's the IIEF MSM, which is modified for MSM. But despite modifications, there's really no instruments that currently exist to measure sexual function for receptive partners. There's really no way to measure sexual pleasure for receptive partners. And that pleasure is likely multifactorial. There's the pudendal nerve for anal stimulation. There's the pelvic nerves and hypogastric nerves. It's unclear how prostatectomy or radiation impacts this function, and there's just currently no way to track changes of function after treatment. So when it comes to special considerations, things we don't often think about when it comes to prostate cancer treatment for our patients, there's this study that came out of MSK looking at radiation doses from brachytherapy with two types of seeds, so iodine-125 or palladium-103. We typically think about asking people to refrain from spooning or having children on their laps, or refraining from close contact. But when you think about the mechanics of sex for these men, there's potentially a chance for the top partner or the inserted partner to have radiation exposure during intercourse. So they looked at different types of exposure and how much radiation they got with each kind of seed. So in total, they had 120 patients. 20 were treated with iodine, 34 were treated with palladium, and then 48 got palladium with XRT combo. And the reason this is interesting is because iodine has a half-life of about 60 days and palladium has a half-life of 17 days, which is much shorter. They calculated a penile tissue radiation dose limit to be 2 centigrade, and they did that by waiting for gonadal tissue based on the whole body dose. What they found was if you used palladium, the waiting time to resume anal intercourse was 2 months, whereas if you use iodine, it should be about 6 months to get out of what's considered dangerous. So this particular group recommended palladium for sexually active gay and bisexual men engaging in receptive anal intercourse. When it comes to the surgical side of treatment, often a question that gets asked is, when can receptive anal intercourse be resumed after surgery? There's not any data surrounding this, but we did we did send a survey out to academic urologists asking them when they thought it might be safe. And the majority of surgeons thought 4 to 6 weeks or 6 to 8 weeks would be a safe time to resume receptive anal intercourse for men after surgery. Now, getting to prostate cancer in men with HIV. As you probably know, MSM are disproportionately affected. 67% of new infections are men who have sex with men. But the relative risk of developing prostate cancer in men with HIV is 0.7. So it's slightly lower than for people without HIV. And the reason for this is potentially because the AIDS epidemic wiped out a whole generation of men who would otherwise have prostate cancer if they were alive. So there's just not as many men who are gay and have prostate cancer just because they died with AIDS in the 80s. There's also the possibility that there's decreased rates of screening in HIV positive patients. So there's studies looking at rates of screening, and it's 18% of HIV positive patients versus 57% of the general population over 50. And then protease inhibitors have shown some anti-neoplastic effect on some cancers, including prostate cancer, but this is just in the lab. There appears to be no benefit to screening HIV-infected men at an earlier age, and there's no effect of HIV on PSA levels. When it comes to treatment outcomes in HIV-infected men, there's a study linking cancer registries and HIV/AIDS registries, and there's over or close to 2 million patients in this particular study. And 6,500 of them were HIV-infected. What they found was prostate cancer specific mortality was higher in HIV-infected patients with a hazard ratio of 1.57. But when you adjusted for treatment, the hazard ratio became non-significant. And what that suggests is disparities in receiving cancer treatment plays a role here. So HIV-infected men are less likely to receive treatment with an odds ratio of 1.8. And people with lower CD4 counts, African-American men with HIV, people who contracted HIV from IV drug use, and HIV-infected people who were 45 to 64 had a lower rate of treatment, is what this study found. And what a different study found was that HIV-infected men are more likely to receive radiation and less likely to get surgery. And the reason they thought this was true was because they thought that surgeons generally were uncomfortable operating on HIV-infected patients at this particular time when this study was done. At least that's how they explained this. And so HIV-infected patients were referred to radiation more often. In terms of treatment responses and side effects for HIV patients, there's a similar therapeutic benefit to treatment, similar rates of disease-free survival when stratified by treatment. There's no increase in opportunistic infections in HIV-infected men status post-surgery. And then external beam radiation leads to decreased CD4 counts, but it recovers to baseline in 2 to 4 years. Moving on to prostate cancer in transgender patients. Prostate cancer in transgender women who choose to have gender-affirming hormone therapy, their body is deprived of androgens and they're supplemented with estrogens. The reported numbers of prostate cancer cases are very small. There are about 12 case reports, and about 60% of these women present with metastatic disease. Gurin studied 2,300 transgender women, and the prevalence here was 0.04%, so it was very low. And then given the low testosterone environment, PSA of 4 doesn't often make sense for these women. So there's no great data behind this, but they were recommending a PSA cutoff of 1 to trigger a biopsy. So, we talked about this paper. Are physicians comfortable with LGBT patients and colleagues? This was obviously done among all kinds of physicians and not urologists. So what our group did was we sent a survey to 154 academic urologists in 2019, and we asked them, do you think gay and bisexual patients have different health concerns concerning prostate cancer than straight patients? And about half of them said, yeah, the concerns are probably similar, and about half said there are probably unique differences in how gay and bisexual men and straight men experience prostate cancer. And then we asked a series of questions. So these are all questions where the answer is true based on current data. And we asked them to give us a true-false response. So when asked if gay men show more bother with anti-ejaculation than straight men, only about 21% got that right. When asked if gay men were at increased risk for anal cancer, 65% of respondents got that right. And LGBT patients may avoid accessing healthcare due to difficulty communicating with providers. 61% of urologists responding got that correct as well. When we asked these providers if they felt comfortable discussing sexual health with patients, they were equally comfortable discussing sexual health concerns with straight and gay patients. And when it came to the amount of time they got in formal education on LGBT health, the majority of respondents had less than 5 hours of formal education in LGBT health. But a lot of these physicians did say that they would like more educational events through professional organizations about LGBT health needs. So as a result of all of this, this led to the creation of the Gay and Bisexual Men's Urology program here at Northwestern. So the idea was conceived in 2018 by Dr. Schaefer after there was preliminary research showing disparities in LGBT patients. And the vision here was to partner with primary care doctors, social workers, sex therapists within the NM system and provide LGBTQ affirming culturally appropriate urologic care. We also wanted to obtain data on urologic healthcare needs of gay and bisexual men, and then create a blueprint to set something up, something similar across the country. So the clinic is structured. We have clinics at Galter on the 20th floor where there's a social worker on site. Here we do clinic and procedural visits, and then on Tuesdays and Thursdays we see patients in North Halstead, where we partner with 17 PCPs, and their patient panels are enriched in LGBT patients. We also partner with sex therapists within the NM system, as well as LGBT-focused therapists in the community, particularly in the North Halstead area. When we started, we needed to get the word out, so we had some media advertising through Facebook, which led to our landing page, where people could come in and see how healthcare would be different. There were some videos for them explaining disparities in screening. And then there was a New York Times article recently that gave prostate cancer in LGBT patients or in gay and bisexual men more of a spotlight. And that's increased the traffic to the clinic. So there's more awareness about different health needs for this population. So our plan is to collaborate more with other departments and kind of build on this program and create more of a research infrastructure to collect data on gay and bisexual men with prostate cancer. So in summary, rates of screening for prostate cancer are similar between gay and bisexual men and straight men. There's lower health-related quality of life when you look at gay and bisexual men compared to straight men. There are lower rates of ED, but higher rates of bother from ED and ejaculatory dysfunction. Treatment can lead to changes in role and sexual identity, and the tools to measure sexual function are sometimes inadequate. And there's differences in counseling for brachytherapy patients regarding radiation, safety, especially important in men engaging in anal intercourse. Patients with HIV have worse outcomes when diagnosed with prostate cancer, but if they're treated appropriately, that appears to disappear. Trans women are also affected by prostate cancer, and a PSA cutoff of 1 is recommended. And then more education is desired by healthcare providers. So that's it for right now. I'm happy to take any questions.
Channa, that was a spectacular presentation, and just so much, so much to unpack. I mean, there's just so many unknowns. And what are you most passionate about right now? Like, where you really want to dive in and kind of first get in the deep end? What areas are you going to focus on, let's just say, in the first 6 or 12 months where you're, kind of building out the program?
Yeah, I think the most important to me is to collect data on these patients. So without data, it's hard to sort of figure out what's going on. So it's to create like a way to get to track the patients that come in and see what they're coming in for, and how they're doing after treatment and how they experience treatment maybe differently than other people. And part of that is creating a tool to measure sexual function a little more completely. So if you look at sexual function just in the form of erectile function, that doesn't seem to work for this population. So there's got to be a validated or different questionnaire for gay men that includes both anal dyspareunia, or pain with anal intercourse, and pleasure, and to help track progress for people that have, non-vaginal sex over time.
We've talked about that, and to formally do that requires some time and effort, but we're going to also just propose your own questionnaire, right? And then we can think about validating that secondarily, because I think that would probably be helpful when you're just wanting to collect the data, right? Because then you'll just get a landscape of like, well, what do people like, and how does it affect them or influence them, right?
Right.
Hi, Channa. This is Brittany. I'm the genetic counselor with the department. I don't know if we've had the pleasure of meeting yet, but thank you so much for this talk. It got me thinking about a trans woman that I met with who actually had a known BRCA mutation in the family. So I was meeting with her for risk assessment and to do testing, and there's just such limited data in the trans community about like hereditary cancer, about cancer screening and risk for these different cancers. And I would just love to hear if you've had any experience with this in your clinic, or if this is something that you've like thought about exploring with your clinic.
No, absolutely. It's nice to meet you, Brittany. So I've thought about the best way to screen these patients, and with a rate of prostate cancer of 0.04, at least in like the studies that exist, it's a matter of how aggressively you want to screen these people. When it comes to like, it's really hard to remember to screen for prostate cancer in trans women sometimes, just because you forget that they have a prostate. So in terms of like, screening for like BRCA mutations, I haven't seen any patients with like a BRCA mutation, but I just, make it a point to screen with a PSA for every trans woman that comes to my office, if they're over the age of like 55, just to get a sense of what their baseline is and kind of track that over time. Even though the data shows like a 0.04 rate of cancer, like this population isn't well tracked within population registries. So I'm not sure we can sort of hang our hat on that number. I'm not sure that that's a real number.
Yeah, and I think too, it's a great question, and there's lots to unpack. The variables in those scenarios are, when were the hormones initiated, i.e. the age of the individual, because there's a correlation between DNA damage and testosterone levels in the prostate. So one could hypothesize or surmise, if you're talking about someone who initiated, hormonal therapy, hormones, I should say, at an early age, that their lifetime risk of prostate cancer would probably be different than somebody who maybe has a focus of cancer because they initiated hormone therapy at age 60 or 55, and that nidus could then become castrate resistant, because obviously early prostate cancer was treated by Dr. Huggins with estrogen, right? So there's a lot of things to kind of unpack. It's a pretty cool thought. Of course, I'm sure you told her, Brittany, that she needs to be screened for breast cancer, because that she'll still have mammary tissue, and that certainly is be important. But
Yeah,
you know, as a follow up to this, Channa, you know, there's already a million things to do. And when we first met about this, you laid out what you wanted to do in your 1 year of research with us with Dr. Kundu, and I told you, well, that was a career's worth of work. So you've just again highlighted that you have a career's worth of work to do here, which is great. The other thing to think about is if you can find an interested, engaged, enthusiastic medical oncologist, I guarantee you that there's going to be a lot of issues that need to be addressed in gay and bisexual men who have advanced prostate cancer and are on systemic therapy. Health-related quality of life measures and appropriate measures of them that may be unique to gay and bisexual men are I'm sure are absent, right? Because they don't, it's just a even smaller entity.
Absolutely, yeah. I'd have to say, just my experience with those patients in clinic, it seems to be very different for gay and bisexual men compared to the straight patients that come see me with metastatic prostate cancer who are on some kind of systemic therapy. It seems to bother gay and bisexual men a lot more, but it'd be interesting to see.
I mean, it's a good question. I mean, there is good data about how much it bothers most straight men, but how it bothers them and so forth may be different. I mean, it's pretty, it's pretty brutal treatment. Of course, it's designed to prolong life, but another opportunity. And, I bet you that there's someone out there who'd be interested in partnering with you on it,
Well, that's great. And I think, Channa, you did talk about this maybe briefly, but, Channa has, for the ones of you there at Northwestern, Dr. Amarasekera has developed some content like for the discharge instructions, patient information, handouts that are, specific for the gay and bisexual male community. And that's been helpful in my practice. A lot of the other material that I have been using, I didn't realize how heteronormative it was. So that's very widely available. And if you need that or need to know where to find it, you can ask me and my staff or Dr. Amarasekera's staff as well. And thanks again. It's a great presentation.
Thanks, Dr. Ross. Great being here.